Thank you very much. Next, we have Dr. Michael Wasserman, who's the past president of the California Association of Long-Term Care Medicine. Dr. Wasserman.
Thank you. Chairman Ting, committee members, those who say we didn't know what was coming to nursing homes in March and April weren't listening to the experts in geriatrics and long-term care medicine. On March 9th, I told NBC News that the coronavirus was the greatest threat to nursing home residents that we have seen. On March 25th, I told CBS that nursing homes could become our killing fields. My experience as a clinical and quality expert, in addition to having been the CEO of the largest nursing home chain in California, gave me a unique perspective into COVID-19 and the measures that need to be taken to reduce its impact and devastation. I want to thank Assemblyman Wood for bringing AB 2644 into law. Its requirement of a full-time equivalent of an infection preventionist in every nursing home is the type of workforce change that is necessary to protect vulnerable nursing home residents. But it's only the beginning. I come here today as immediate past president of the California Association of Long-Term Care Medicine and current chair of our Public Policy Committee to make recommendations that are actionable and sustainable as we move forward. Today's nursing homes are essentially mini hospitals, regardless of whether they deliver post-acute care or provide long-term care to the most frail, complex, and challenging population of patients in our history. The average nursing home resident has multiple chronic conditions, cognitive impairment, and requires professional oversight and care from a broad array of caregivers and healthcare professionals. Historically, a major role of the nursing home administrator has been to put heads in beds. The medical director, by federal regulation, is supposed to be the clinical leader of a nursing home. In usual practice, unfortunately, medical directors are often separated from clinical policy discussions and decisions. Registered nurses, as professionals who are trained to assess patients, are sometimes not available to make necessary assessments in real time. How do we run mini hospitals without the clinical leadership and staffing that are so vital? COVID-19 has brutally exposed this weakness. There is now ample literature to demonstrate that 24-hour RN coverage and a minimum of 45 minutes of RN staffing per resident per day, along with enough LVN and CNA coverage, leads to fewer COVID-19 outbreaks and deaths. Consultant pharmacists must also be engaged to the fullest extent. I can tell you, based on over 30 years of experience in the field of geriatrics, that having a competent and engaged medical director to work with the nursing staff and the infection preventionist, as well as to guide administrators who have little clinical expertise, has played an important role in battling this scourge throughout the state and country. I am a faculty member for the American Board of Post-Acute and Long-Term Care Medical Director Certification course, as I recently participated in the 3-day course that completes the training. All I could think of was what a difference it would have made if every nursing home in the state had a certified medical director over the past 8 months. I guarantee you that if that had been the case, and in conjunction with the appropriate nurse staffing levels, far fewer nursing home residents would have died. Every nursing home in the state already has a medical director, and nursing home owners already spend a significant amount of money on medical director stipends. By requiring certification, you will assure that nursing home medical directors have the tools, the skills, and the professional obligation to provide qualified oversight. This will not increase costs to the state or the industry, but it will improve quality and accountability. There is also evidence-based literature that demonstrates a correlation between for-profit status and the size of COVID-19 outbreaks and deaths. The motivation for profit must sometimes be reined in to avoid harming the customer. Manipulation of existing related party transaction reporting can also skew actual facility-level profitability. This is why we must have complete transparency around the ownership structure, as well as giving strong consideration to a medical loss ratio parameter for nursing homes. Last, but certainly not least, CNAs, the true heroes of this pandemic, must be treated with the respect and dignity they so richly deserve and finally earn a living wage. I also encourage you to pay extra attention to the comments of Nicole Howe and Dr. Charlene Harrington. I respect and value their insight and opinions. Thank you for this opportunity, and I look forward to answering your questions.
Thank you, Dr. Wasserman. Next we have Maria Carmen, who's a certified nursing assistant representing SEIU.
The ombudsman program.
Mr. Fong, so I was just going to say, I know Dr. Wasserman wanted to jump in if you were interested in hearing.
Absolutely. I'm sorry. If anyone wanted to jump in, I apologize. I just
Not
kind
at
of
all.
targeted.
I'm just going to make sure it's okay with you.
Absolutely.
Dr.
Mr.
Wasserman?
Ready? Thank you so much. It's a little bit of a challenge from the being virtual. So, I actually had a few things I could comment on, but I wanted to preface it with a word I've come to understand over the last 8 months, which is the word stakeholder. And I want to commend CDPH for engaging the Geriatric Council and CALTCM. We are not stakeholders. We are subject matter experts. And I really continue to be challenged by how the process works, where stakeholders have their input and the subject matter experts are not included in discussions that drive policy that make decisions. I'll give you a few examples. We didn't have geriatricians or experts in long-term care medicine on the testing task force, and that led to significant delays in knowledge regarding response to testing. I did want to comment on the overall mortality, and I do agree that the state has done an incredible job of putting into action a number of mechanisms and mitigation efforts that have reduced mortality. But I'm going to give you a couple caveats. Almost many of those recommendations were made by the experts in March and took till June, July, August, September, October before they were implemented. Lives could have been saved. And and the other thing that I think a lot of folks don't realize, as a geriatrician looking at the numbers for 8 months and the data, one of the reasons overall mortality has gone down is because we're improving in our efforts, but it's also because the most frail members of our nursing homes have already died. So, and they're not being replaced. And so the data, I'm not surprised that mortality rates are lower now. And the thing that concerns me is, while we've made improvements, vulnerable older adults continue to die every week. And I just want to make sure that we don't look at this as, hey, we're doing great. We are still losing vulnerable residents. We are still losing frontline staff. I also wanted to comment on the VA. I've been in touch with my VA colleagues from the beginning, and the VA is a great example of having geriatricians involved, having engaged medical directors involved, having enough staffing involved. Dr. Tom Yoshikawa was actually on one of our expert groups. He's at the VA in West Los Angeles that made recommendations around testing that we published at the end of May. So I think the VA is a great example of what works, and I strongly recommend we look at that as a positive. The other thing was, the question was asked about the vaccine prioritization. I actually had the honor of serving on the National Academy of Science committee that made recommendations for the allocation of the vaccine. And there's no question that frontline nursing home staff are one of the most important groups to get vaccinated. But what we've actually convened another group of experts to make recommendations and give guidance at the state federal level, because what you've heard today is the tip of the iceberg of the challenges that are going to occur when we start trying to implement vaccine with the frontline staff. And again, I know this is not necessarily a forum for hearing all those details. I am happy to share that with your staff. But this is not going to be easy. And in fact, the way the federal government has set up the process, they have basically given responsibility to CVS and Walgreens to vaccinate nursing home residents. They've given each state the responsibility to decide how the nursing home staff are vaccinated. And that creates, and I've actually been in touch with some of the major vaccine manufacturers. They haven't been given a lot of great direction by the feds. So there's a lot more confusion around this than anyone is telling you right now. And I think that's really important. So those are the things up to this point that I really just wanted to make sure I made some comments on, and I appreciate the opportunity to share them. I know it's a little bit difficult in this sort of setting here.
Okay. Thank you. Appreciate it. Dr. Wasserman, and these are my last series of questions. So, all right. A couple questions for you, Dr. Wasserman. There we are. First of all, can you talk about SNF and the third party issue, kind of the need for transparency? I know about the audit. I'm the one who initiated the audit. So, but I'm curious as how this relates to the CARES Act and how the money from CARES Act has been disseminated and utilized by skilled nursing facilities.
Yeah, thank you, Assemblyman. Appreciate the question. So I think the concern that some of us have had is how the money from the CARES Act has actually flowed to facilities, and whether that money is being spent 100% towards direct patient care, whether it be hazard pay, whether it be PPE, whether it be testing. And I think one of the challenges is there's multiple ways that money can, for lack of a better word, be siphoned away. For instance, you've mentioned related parties. The cost report doesn't capture all related parties, number one. So in order to really know some of these answers, we need full transparency on all of the related parties. Similarly, we need to get into a level of detail. For example, what are facilities paying, say, to a related party supplier for their PPE? Are they paying market rates? Are they paying over market rates? There's a lot of ways that the system, the money can be manipulated, and all at the same time, if some of that money is going away from the facility, it's not being used to pay our frontline staff who are putting their lives at risk. And I think that's a great concern. I think the real question here is we need a full amount of transparency of all these issues.
Thank you. Couple things other things you mentioned in your comments and recommendation in particular. One was a 24-hour RN on duty. I was kind of appalled to realize and know and understand that a facility does not require a 24-hour nurse, an RN. We're not talking about a medical doctor. We're not talking about nurse practitioners. We're talking about an RN. So I'm going to guess that at some point, as things wind down in the evening, it's LVNs and CNAs, and you know, I'm concerned about that, and I would imagine that those consumers aren't aware of it. We certainly weren't aware of it, and you know, I just can't help but think that a change in that direction would be a dramatic potential improvement in the quality of care and the quality of the health of the residents, so that something early can be caught. And you know, things happen in the middle of the night. You know, I mean, they clearly do in hospitals and wherever. I'm just shocked, quite frankly, that there isn't a requirement to have a nurse, an RN, in the building 24 hours a day, at a minimum.
Yeah.
Go ahead.
You and my wife, I was preparing for this, and she had the exact same reaction. She was like, wait a minute, I would have assumed this. And keep in mind, aside from the level of acuity of patients coming from the hospital, the residents in our facilities have multiple medical issues. And so there's actually a couple key points here. Facilities with under 99 beds are not required to have a 24/7 RN. And we need to change that because, as you said, in the middle of the night, someone's not feeling good. Who can evaluate them that has any licensed professional clinical expertise? And it must be a registered nurse. Now, we have to go beyond that because in larger size buildings, there may be an RN, though, surprisingly, even though it's required for there to be 24/7 RN for facilities greater than 100 beds, that doesn't always happen. And I think that is something that really needs to be monitored by the state as well. But even with a 24-hour nurse available, if things go wrong with a few patients at the same time, a few residents at the same time, one person is not enough. And that's where the 0.75 RN per 24 hours per resident per day comes in that Dr. Harrington spoke of. And, we really have to realize we're not running apartments here. We're running mini hospitals, and at the very least, we need a registered nurse who's available, who's not pulled in multiple directions. And I have to tell you, my heart breaks for the stories I heard Nicole Houtel and others in terms of what's going on in understaffed facilities right now that we don't know about. And during COVID, there's a lot more complexity than we've ever had. And so the need for that 24/7, 0.75, full staffing is absolutely essential if we're going to provide even a modicum of care for our loved ones.
Thank you. You also talked about certified medical directors, and you also mentioned that the course is not terribly onerous. I mean, but it's probably technically onerous, but as far as the time involved, it's a three-day course. And I'm thinking about rural communities where often it's really difficult to even find a doctor who could, who would be willing to be on paper the medical director. Have you thought about other potential providers who might be able to fill a role like that? In some communities, you may not find a doctor, but maybe it's a nurse practitioner. I don't know, but somebody who could be on site more, because my sense is that a lot of this is they're on paper more than they're on site, and it doesn't sound like from your conversation that they're really involved in decisions around the medical treatment of as far as the treatment of the residents. It sounds more like an administrative position where they kind of come in and sign a few papers occasionally, and then they're gone again. So now, if the goal is to have better care, the certification makes a difference. But there are probably settings where it's going to be really difficult. It's probably difficult now, but extremely difficult to get staff to do this.
No, that is a great question, Assemblyman. And first off, the course has online coursework, and then it ends with a 3-day sort of wrap-up that used to be in person but is now virtual. But, rural areas have struggled regarding nursing homes for as long as I've been a geriatrician, which is over 30 years. And actually, back when I was in Colorado, we actually had a grant go out to rural areas to try to help physicians deal with their older population. And so this is an ongoing problem, whether it's actually having clinicians who go to the facilities or having a medical director who is on site at the facility. And in rural areas, often the person who sees patients is also going to be the medical director, which has some of its own challenges. But I think one of the things we've learned during COVID is the opportunity to provide telehealth, telemedicine, virtual availability. In fact, the facility I'm medical director of, because of my age and I had asthma as a kid and my wife has some immunocompromise, I haven't been in that facility since the onset of COVID, but I have continued to interact with the staff and with the leadership of the facility. So there are many ways and in fact, I think one of the solutions here for rural areas is going to be providing telehealth to the nursing homes for both clinical care and medical director leadership. And to your point, most medical directors unfortunately get a nice stipend, and for that stipend they go in and they spend an hour or two a month signing papers. That is not what the regs meant them to do. That's not what they're supposed to do. That's not what we need them to do. And one of the things that really I feel strongly about, I'm a professional, you're a professional. If a physician doesn't have the tools and the training, then they don't have their own expectation of what they can do. But once you put in their hands the training, the tools, the skills, 95% of physicians that I know will take that responsibility seriously. And all of a sudden, you have medical directors who are going to get more involved in whether a facility is up to speed staffing-wise in order to take complex residents. As one of my colleagues and I said early on in COVID, when the state actually tried to send COVID patients into nursing homes, my colleague and I said we'd stand in front of our facility and keep those people out, because as we all know, and the experts knew in March, the nursing home residents aren't bringing COVID into the facility. It's visitors, it's staff, it's vendors. And so if you have an engaged medical director who's actively involved with the administrator, with the director of nursing, and they know that that person is responsible for the clinical care, then you have an additional means, you have additional eyes and ears beyond the state surveyors, beyond everyone else. You've got professionals who are going to be part of the solution rather than part of the problem.
One final question for you, and thank you to the chair for indulging me here. Is we talked about we went back earlier. We talked about the transparency, about the need for transparency around how the CARES Act money may have been utilized. Was there what was the formula for what how nursing homes qualified to get it? And I bring this up because yesterday we found out in our hearing on healthcare affordability that hospitals, often the hospitals that had the best balance sheets, got the lion's share of the money because of their Medicare populations and so on. Yet the hospitals that probably needed it the most didn't get that, didn't get anywhere close to what they needed yet. So it's it's those who have the gold get more gold, and those who don't. And so I'm curious, in this industry, how was the money disseminated? What did that look like? Did the biggest, wealthiest systems get the money, or was it fairly disseminated? We can't hear you though.
I actually heard the question,
Okay.
and then it froze.
Okay, all right. Oops, hang on, we lost you.
It's interesting when
Go ahead, we can hear you now. Go ahead.
So when the CARES Act came out, there really was they just gave the money out, and there really wasn't a lot attached to it. I think the larger organizations, as you said, with the most money, the most resources, probably were better able to access those funds. I worry in these cases for the not-for-profits, the mom and pops, the sole-owned facilities, in order whether they were able to put in their request and get the money. In terms of, from my understanding, from talking to actually staffers in Congress, there wasn't a lot attached to this. So the money just came out, and I think a lot of folks are beginning to look at what actually happened to it, and just as you are asking that question.
Okay, thank you. Well, I guess we'll continue to look at it then and see. So, have you heard? Is the federal government plan to do any audit on on CARES Act and how it was spent?
I've actually spoken to staff on the congressional subcommittee that's looking at this, and it is my belief that they are going to be looking at this.
Okay, great. Thank you.
So I don't know if my colleague, Dr. Wood, was thinking about this, but I think something along the lines of ensuring that housing, owner-operators are also disinvested from ownership of the property potentially helps address at least one of these issues. I don't know if you would care to comment, Mr. Cornett, on that, but I'd like to hear it from you as well as from Dr. Wasserman.
Yeah, I would probably need to understand a little bit more what you're talking about. I will just tell you this, though. The many facilities around the country, less so in California, but many facilities around the country that have not been able to make it and have gone bankrupt over the last number of years, the cause of that has been the REITs. The REITs and the ownership of the land. That has been a major problem in many parts of the United States, because as the REITs have increased the lease cost, that is something that the facilities have not been able to manage, given that. So I would say I'd be cautious about anything that we look at here, given the experience we've seen in other states.
So you've seen that in other states, but has that been the issue in California?
That has been an issue in California as well. I'm just saying I don't think it has been as dramatic in terms of forcing facilities into foreclosure and into bankruptcy as much, but it is definitely an issue here because we've seen that the REITs have run up the cost, to the extent that they don't. Now, there's different models. There's different models out there. Some facilities, I'm just thinking of one local facility here that's been a family-operated facility for 3 generations. That facility owner owns the facility and also operates the building too. In many cases, someone else owns the facility, owns the land, owns the dirt, if you will, and the facility, and the operator that operates the facility, and then a major part of what they have to pay then is they have to pay the cost of the lease and usually to a REIT.
Okay, but I raise this because I think there needs to be a clear distinction between the person who owns the property and the person who's getting into the business and is going to make sure that every dollar is invested for the best interest of the healthcare outcomes and the best providing the best service through a model that they know works, rather than making sure that various costs are addressed, and then there isn't much left for the services that need to be rendered or provided. It's a very clear distinction for me, and I again, that's why I took steps in the charter arena, education arena, to make sure that motivation was not there, and maybe that's something that we need to also. I'm certainly going to want to look at in the coming year, because we've seen this in other settings, in group homes, in many other settings, where the state will provide us certain amount of dollars, and I wonder to what extent some of these folks who conduct this business, once their property is paid off, will then quite simply either sell the business or abandon the business. I'm interested now to know if there are any numbers in that, but this is, I'm going into areas that I wasn't even thinking of before this hearing. So I'd be very curious to explore that as well. Mr. Wasserman, would you like to comment on some of the questions I'm asking about the related party companies and certain practices and the level of enforcement?
So there's a bit of a time delay, so I was just listening to the end of the question. I'm actually really pleased that Mr. Cornett brought up the REITs. I couldn't agree more that the real estate pressure on nursing homes has been a long-standing issue. And if you actually look at some of the large, even publicly traded nursing home companies, the REITs sit on the boards of those companies. If you then look at owners of nursing homes as well as owning nursing homes and operations, when you have the same people owning the land, owning the real estate, and owning the property, as Mr. Cornett is very skillful, very correctly pointed out, they can apply pressure to the operations that can impact their ability to succeed and often end up leading them into bankruptcy if that pressure is too great. I mean, there are a myriad number of examples of this over the last 20, 30 years. So I actually think Ms. Cornett has really helped explain the fact that there are untoward pressures from real estate on the operations of nursing homes that are meant to be places where we provide care for very vulnerable people. And we really need to look for a way of either separating out this pressure, making changes to it, and I think there's a number of ideas that could be out there.
Very interested to discuss all these different pressure points and seeing how we can start implementing all of these different pressure points into some kind of an executable either policy or legislation that starts untangling certain influences from being able to deliver the best possible care as well. I think it would actually help also CAF within its own institution to be able to maybe make those separations. By the way, since Dr. Wasserman, since you're there right now, is you started to touch on the vaccine task force and the geriatric medicine background. Do you know how many members there are on the task force?
So the governor has put together a work group to determine the safety and efficacy of the vaccine. And keep in mind, most of the vaccines that are out there that are being tested right now, only one to my knowledge has even ventured into nursing homes to have nursing home residents entered into those clinical trials. Even amongst the other ones, the upper age is often 65 or 75. We do have some that did go up to 85, and that's encouraging. So that's number one from a starting point. So when this vaccine gets approved, we really need to evaluate it. And in order to evaluate the safety and efficacy of this vaccine as it relates to older adults, we will need colleagues of mine, folks like myself, who have expertise in geriatrics and long-term care medicine, and there is not a single member of the vaccine work group with that expertise. The majority of the physicians on that work group are pediatricians, which I understand because pediatricians are very involved when it comes to vaccines. But when it comes to opining on whether these vaccines are going to be safe and effective for nursing home residents, for people over 65 in our other communities, we need experts to be part of that.
Harrington and Wasserman want to offer some thoughts on this?
We good? Yeah, I definitely, this goes to the issue of how we keep and maintain CNAs in our nursing homes. And there's a bit of a false narrative out there that it's hard to get good people, it's hard to keep them. I will tell you, I've been doing this for 30 years. If you find really top-notch facilities, 5-star facilities, very successful facilities, you often find CNAs who have been working there 20 or 30 years. So here's the deal. It's about leadership, it's about respect. So if you have the right culture in your facility and your CNAs feel respected and acknowledged and cared for, and then the other side of that is you've got to pay them a living wage. If they have to work 2 jobs, it's going to be really hard for them to be that committed to your facility. So I think it's a combination of adequate wages as well as respect and strong leadership from the facility in terms of absolutely respecting and appreciating the CNAs. So I think, part of the theme here when it comes to CNAs is we have a lot of work to do. This is not somewhere where we just say, okay, let's give them hazard pay, and now they're going to come. I mean, if they're not treated well, they're not going to come. And again, I'm not saying that there's any necessary across-the-board generalization of CNAs not being treated well. What I am saying is this is something the industry really needs to look at. And I would, sort of double down on everything Nicole House said about how we train these folks and then how, as facilities, we treat these frontline heroes that we need so desperately. And I think if we treat them well and pay them well, I think we will not have the staffing issues that we're talking about here. And one last comment on the waivers. To me, I get the waivers from a business perspective. I don't get the waivers as a clinician. When you're basically saying we cannot provide an adequate level of care for our residents, but we're giving a waiver because the facility has trouble getting them, I as a clinician, I just don't understand that.
And thank you.
Didn't know who was going to go first. I'm trying to get the question. Remind me the topic.
I defer to Dr. Wasserman if you have any other questions on that. Then, but Mr. Singh, just like I said, just to let you know, the surveyors are in the buildings at least every 6 weeks now, and in some cases more, to check on the mitigation plans and see how facilities are doing. And so, just in terms of oversight, I'm not sure that answered your question, but.
Okay. Yeah. No, I'm good. I was thinking about what that brave soul was sharing with us. I would like to say that as of late, my organization has been working closely with CDPH, We've actually begun to develop some education training for surveyors around working with or asking questions of and interviewing the medical directors, the consultant pharmacists. And so we actually really appreciate those efforts, and we think, to Ms. Steneker's point, that one of the challenges of the survey process is how you impact poor leadership in a facility. And I think you begin to impact that by asking more questions of all the leaders in the facility, the administrator, the director of nursing, the medical director, the consultant pharmacist, and such. So, look, I think there's a lot that we can learn from what's happened over the last 8 months. I think there's been positive movement in terms of looking at how we approach these processes. I absolutely agree that we need to continue down that path, and we can find fault in what we've done wrong, but I think what we need to do is start figuring out what's next. And I will share, CALTCM has actually submitted a grant proposal through the CMP funds to provide leadership and management training to facility leadership teams. And I feel very strongly that during a crisis, leadership is absolutely essential. And I don't think there's any space amongst all of us to recognize that if you don't have strong, solid leadership in a nursing facility, especially during a pandemic, you're going to have problems and you're going to have poor outcomes. So I think that's really one of the key areas for all of us to be looking at.
Dr. Wasserman, just going back to you, just the same kind of question. You mentioned, more RN coverage, more resources. How do we do it? I assume if the facilities had the money to do this, they'd already be doing it. So how does this become a reality?
Okay, can you hear me okay?
We can hear you great.
Having a little feedback here. We good? Okay. So actually, I'll frame this two ways. First, the nursing home industry is at an inflection point right now, and we have to do something. And one of the best examples I'll give you is what Assemblyman did with his bill. We recommended the second week of March that every nursing home in the state have a full-time infection preventionist. And I will tell you what we heard from various folks was, we can't afford that. And my response was, you can't afford not to. There is something called investing in quality so that you have better outcomes and you save money. And so I question the premise that certain investments in staffing necessarily are going to lead to a net loss of money. And, we have not-for-profits that do fine. And so I honestly think the industry needs to look in the mirror and decide, as both Mr. Nazarian and Wood mentioned, where does the real estate flow? Where do the funds flow? I said it in the assembly hearing to the health committees back in June. The large nursing home chains in this state and across the country could easily have leveraged their assets to acquire abundant PPE and testing in March and April when the experts were saying that's what we needed. They had no fiduciary responsibility to do that, and they didn't. Actually, I want to take a step on that.
So are you
there
saying,
are some
Dr. Wasserman,
operators
Dr.
who
Wasserman?
did.
So are you just saying they could bring in more people, now they're just choosing not to because of profit? Because we haven't seen the same amount of infection rates or problems in the nonprofit sector that, in essence, would be dealing with even a poor clientele. So is that what you're saying? We could do it right now, it's just the profit motives getting in the way? I'm just trying to understand what you're saying.
That's a great question. And actually, there is data showing fewer outbreaks, fewer deaths in not-for-profits versus for-profit. And look, I'm an entrepreneur. I believe in the profit motive. At the same time, we can't abuse that privilege. And I think the industry really has to take a hard look at how much money it wants to make and where it wants to make it. And that's where all the other transparency issues come in. I don't think the state should have to spend extra money. And in fact, the reason we recommended that full-time infection preventionist back in March was that wouldn't cost the state a cent. And in fact, it would take people that the nursing homes already had, because every nursing home already has an infection preventionist. It's just that they're typically pulled in 12 different directions and not allowed to do their job. And to be very honest, in a lot of ways, there was just resistance because folks don't understand that you have to invest in doing the right thing and providing quality care in order to be profitable. That is what I believe, and I think that is sort of a mantra I believe in. And I too would be happy to spend time with your staff too in terms of, I love numbers. And I do believe that this industry can survive, but they're going to have to make a huge decision in terms of how much profit and where that profit's going to be if they do want to survive.
Thank you, Dr. Wasserman. Just for one